This morning I'm talking about quite a large topic, recurrent elbow instability, diagnosis and treatment. This is based on a AOS review article from this year. So important to sort of just understand the biomechanics of the elbow joint, which is a stable hinge-type synovial joint. And you can look at the stabilizers in terms of primary and secondary. So obviously your primary stabilizers are the articular surfaces, the ulnohumeral and radiocapitellar articulations, and the anterior bundle of the medial collateral ligament is very important, and the lateral collateral ligament complex, which I'll talk about a bit later. The secondary stabilizers we have are the radial head, the joint capsule, and the muscles around the joint, which provide dynamic stability. So the ulnohumeral joint is the joint where the trochlea mates with the greater sigmoid notch of the ulna, and the coronoid supports this articulation anteriorly. The contribution of the articular and soft tissue constraints of the elbow depend on the degree of elbow flexion and the type of varus valgus force applied to the joint. The lateral collateral ligament complex is a series of ligaments. The lateral ulnar collateral ligament, which is tight in flexion and lax in extension, is the most important primary stabilizer and is superficial, followed more deeply by the annular ligament and more deeply still by the radial collateral ligament, which is a deep part, which fuses with a deep part of the joint capsule. ECU tendon and the supinator tendon, which the supinator merges with the lateral collateral ligament, also resist posterolateral instability and have a greater role when the elbow is more flexed. I'll discuss that posterolateral instability a bit later. All of these function to act in unison to give varus stability and prevent posterolateral rotational forces at the ulnohumeral joints. And especially the lateral ulnar collateral ligament acts as a posterior buttress for the radial head to prevent radial head subluxation. So both the lateral ulnar collateral ligament and the radial collateral ligament must fail to compromise elbow stability. The medial ulnar collateral ligament complex is composed of three bundles: anterior, posterior, and transverse. There's a schematic representation there. The anterior bundle, like I've said already, is the primary valgus stabilizer of the elbow joint. There's two functional bands: the anterior band, which is tight in 0 to 60 degrees of flexion, and the posterior one between 60 and 120 degrees. This is important, this ligament, because there's often attritional injury in throwing athletes, and it's especially the early acceleration motion of throwing that it can exceed the tensile strength of the medial ulnar collateral ligament and make it fail. The radial head is a secondary stabilizer, like I've said. It enhances the valgus stability, especially when the medial ulnar collateral ligament is incompetent, and does provide some restraint to posterolateral rotation. The capsule is quite weak, thin and weak, but has some role to play in stability. And the anterior capsule and terminal extension provides resistance to distraction forces and provides some valgus stability. Dynamic secondary stabilizers are the muscles. So brachialis, biceps, and triceps will provide resistance to joint compression forces and increase varus and valgus stability independent of where the forearm is in space. And the common wrist extensors provide some varus stability, as you expect. The flexor pronator muscles, or the flexor pronator mass, are important. I'll discuss those a bit later because they provide some valgus stability. So in terms of functional anatomy, the medial collateral ligament is tight in pronation and the lateral collateral ligament is tight in supination. That's important in terms of rehabilitation of these injuries and what position of the forearm you put patients in, for example, in bracing. Elbow instability is a sort of wide spectrum of disease, from valgus instability, from medial collateral ligament injury, to traumatic recurrent rotatory instability, or iatrogenic damage during surgery. To classify elbow dislocations, you can do it anatomically based on the anatomic location of the olecranon relative to the humerus. And posterolateral dislocations are the most common in over 80%. A simple versus a complex dislocation, simple one where there's no associated fracture, and a complex one is where there's associated fracture. So how is the mechanism is associated with complete or near complete disruption of the capsular ligamentous stabilizers, like I've mentioned. And the progression of the injury is from the lateral complex to the medial side. And the medial collateral ligament fails last, and you'll generally get that with the higher degree of injury. So the mechanism of injury is really just a fall onto outstretched hand. This usually causes posterolateral instability, like I've said, with the elbow slightly flexed and pronated as the hand hits the ground. The humerus internally rotates around your fixed forearm, giving a valgus and external rotation moment on the elbow. And with sufficient force, the radius and ulna will rotate and displace posterolaterally on the distal humerus. And generally, the lateral collateral ligament will always fail with every dislocation. Common extensors in 2/3 will fail, and then anterior bundle of medial collateral ligament in 50% of patients. So the images you've got to think about are radiographs, looking for some calcification or ossification around the lateral epicondyle, which may suggest an avulsion of the lateral collateral ligament. Look at the concentric reduction of the joint post-reduction, and any drop sign, which is indicated by a widening of the ulnohumeral joint. Stress radiographs may or may not be useful, but it's very difficult to reproduce the symptoms and can be quite uncomfortable for the patient, so generally not all that useful. MRI has some role to play, especially in medial collateral ligament injury, because you can assess where the tear is at the origin or the insertion, and use of MRI arthrograms have got increased efficacy in both lateral and medial collateral ligament instability. You're also looking for other injuries such as loose bodies, looking at the flexor pronator muscle mass and the radial head. Dynamic ultrasound has been shown to perhaps have a role, but more of a role in valgus instability rather than lateral collateral ligament instability. And the lateral collateral ligament in some of the studies has been quite difficult to visualize on the MRI scan, so may or may not be of use. Perhaps examination under general anesthesia is better. So for acute elbow dislocation, the non-operative management is generally expedient reduction and splinting at 90 degrees for around 7 to 10 days, and simple stable dislocations, and then start range of motion. You can reduce it and put it in a splint with it in a hinged brace at 90 degrees for 2 to 3 weeks, and simple dislocations where you feel there is particular instability, and then start range of motion with the arm in pronation. For chronic elbow dislocations, operative management is generally open reduction, release the capsule, and a dynamic hinged elbow fixator. That will generally protect any reconstruction that you do and allow early range of motion, but won't maintain your reduction of the elbow. It's generally done through a posterior approach, and it's advisable to fix any other injuries, bony injuries such as radial head fractures first before you do that. If you fix the radial head, generally advised to do so if you can, if not, to replace the radial head, because that radial head arthroplasty has been shown in studies to reduce your risk of posterolateral instability rather than just excision of the radial head. Acute elbow dislocations, operative management are generally to fix what may have been damaged, the coronoid or the radial head. Lateral collateral ligament repair, generally always, plus or minus the medial collateral ligament repair. Sort of gone through that before, but it's important with the radial head, when you're fixing this, you've got to be aware of the safe zone. It's a 90-degree of arc in the radial head that doesn't articulate with the proximal ulna, where you don't want to put fixation in because you may get a mechanical block. And the safe zone you can identify from the relationship of blisters and the radial styloid. Just thought I'd mention the terrible triad injury, which is a traumatic pattern of posterolateral dislocation radial head fracture and coronoid fracture. And it's generally from a traumatic varus stress that causes this and subsequently leads to ulnar collateral ligament rupture. The lateral collateral ligament of injury of the elbow, the mechanism is generally a traumatic varus stress, like I've said, and can cause posterolateral instability. Whereas medial collateral ligament injury is generally due to severe valgus moment on the joint and is seen quite commonly in throwers such as baseball pitchers. And they've got this rupture of the anterior band of the medial ulnar collateral ligament and the flexor pronator mass, which is a secondary restraint like I've mentioned. It may or may not cause elbow dislocation, but can cause avulsion, like I said, of the flexor pronator mass or ulnar nerve symptoms. Can be difficult to identify one from the other. In terms of complications of an elbow dislocation, you can get various posteromedial instability, or generally is what we see quite often is loss of motion. Current instability happens in about 15 to 1/3 of elbow dislocations, and residual laxity is commoner with lateral ligaments rather than medial ligaments. It's thought that the medial ligament heals better than the lateral, but that's sort of going out of vogue with more studies that are being done on this. So posterolateral elbow instability is there's a predictable pattern of capsular and soft tissue injury. So the lateral tissues, like I've said, get disrupted. There's proximal lateral epicondyle avulsion, and there's soft tissue injury to the anterior and posterior capsule. And there's what's called stage 3A and 3B, and that's dependent whether the anterior band of the MCL is intact in a 3A or disrupted in a 3B. So predisposing factors for posterolateral elbow disability are cubitus varus, such as after a malunion for supracondylar fractures, but also lateral epicondylitis, repeat steroid injections, and perhaps iatrogenic weakening of the lateral ligaments from a previous debridement for lateral epicondylitis. Can also occur with the Cocker approach to fixed radial head fractures, where you disrupt the lateral structures. Current posterolateral rotatory instability in terms of your history can be quite subtle to diagnose. It's dependent on elbow position and where the patient will experience the pain. They might get some apprehension in using the elbow. They may feel some clunking or popping or shifting sensations. And generally provocative activities such as pushing up from a chair with the elbow extended can reproduce the symptoms. Clinical indicators in your history that you can ask the patients about are those things such as pushing up from a chair, tabletop test, or attempting a push-up with the forearm supinated. These all simulate the axial load and extension with supination. But often the symptoms and signs are subtle and investigations are not always diagnostic, so you may sometimes need an EUA to confirm the diagnosis. There are some other special tests that you can do. Obviously it's important to assess the range of motion in the varus and valgus stress, but the pivot shift test is a test with the patient supine and the shoulder flexed. And you supinate the forearm and you provide an axial compression to the elbow and a valgus stress, and you should see subluxation of the radial head. The cause of the instability is generally from supination of the ulna from the distal part of the humerus, because the primary stabilizer to prevent this, the ulnar lateral collateral ligament, is damaged, and that's the main aim of your treatment, is to restore this. The radial head, like I said, has got some role in preventing rotatory instability, because as the lateral collateral ligament courses around the radial head to the ulna, the radial head will produce tension in there. That's why radial head excision will increase your risk of posterolateral instability. You can manage these non-operatively. There's not really much evidence in managing these in the literature. Obviously, patient education to avoid whatever provokes their pain, physiotherapy and bracing may be a benefit to encourage range of motion. And you should have a forearm pronated and then allow free range of flexion extension in a hinge brace. pain. There's not much literature on that. In terms of the operative management, indications include your recurrent instability, pain, or mechanical symptoms, and you're aiming to restore the ulnar-humeral joint rotational stability. Acutely, you can do this with a reconstruction of the lateral ulnar collateral ligament, or chronically, a ligament reconstruction with palmaris longus tendon. You can always also use plantaris tendon on an allograft. You can use a docking procedure, which I'll describe shortly, or an interference screw for your fixation. So in terms of the surgical technique, you perform a lateral approach to the distal humerus between the triceps and the brachioradialis. Expose the supinator crest of the ulna to the lateral epicondyle. Incise the antebrachial fascia behind the lateral collateral ligament at the edge of ECU, and incise the lateral collateral ligament parallel to the radial head along the axis of the radial neck. In the paper, they describe using ulnar tunnels, two tunnels, one proximal to the supinator crest, and one even more proximal and behind that at the insertion of the annular ligament. Pass your graft through the tunnel and create a humeral tunnel at the ulnar humeral attachment of the lateral collateral ligament at what they call the isometric point of the lateral epicondyle. So that's basically a circle, at the center of the circle on the capitellum. However, that can be quite difficult to find in a chronic rupture. So generally what they advise is to create your ulnar tunnel, put your graft through, and suture it down, and put the arm through a range of motion. And then where there's equal tension on the sutures, that's where you put your drill hole in the humerus. You can attach your graft with a figure of 8 with diverging tunnels or a docking technique. I'll describe that a bit later. So you repair your capsule first, reduce the elbow, place it in 45 degrees of flexion with the forearm pronated, and then secure your graft to make sure it's extra articular. So they advise splinting the elbow at 90 degrees with the arm pronated for 7 to 10 days. Use a hinged elbow brace with a 30 degrees extension block and start active assisted range of motion for 6 weeks. Flexion and extension and pronation supination at 90 degrees of flexion with no lifting for 6 weeks. Then unlock the brace at 6 weeks, get them going, and then take the brace off at 8 to 12 weeks. And then no restrictions around 4 to 6 months, depending on the patient's compliance. What evidence is there for posterolateral rotary reconstruction? Not that many papers on this. Of the ones that were described in this series, it was 11 patients, 10 of which following this had a stable elbow. 7 reported excellent results, and results the authors felt were related to a competent lateral ulnar collateral ligament. There was also another larger study done by the Mayo Clinic looking at 39 of 44 patients who also had a stable elbow after reconstruction. 3/4 reported a good or an excellent result. And they found that the best outcome was in patients who had the reconstruction from trauma rather than chronic instability. And they found that using a graft was better than using local tissue for the reconstruction. In terms of medial collateral ligament instability, often these symptoms have a gradual onset. They might often, a lot of people who are not throwers may well be asymptomatic. And throwers would generally they'll notice a gradual onset of medial elbow pain during the early acceleration phase of the throw, loss of speed of their pitch, or they may describe a single event with a pop, which is a lot less common. Range of motion is usually normal. The flexor pronator mass you need to examine for tenderness and pain on strength testing, and localized medial tenderness over either the flexor pronator mass or the sublime tubercle of the ulna. Palpate the olecranon and palpate the cubital tunnel and examine the ulnar nerve to make sure there's no subluxation or any compression there. Also important to examine the shoulder to make sure that you assess fully the radiator cuff and there's no element of referred pain. Valgus stress testing should be done with the elbow flexed at 20 degrees in pronation. This can sometimes be difficult to elicit laxity. They suggest that over 3 millimeters of medial ulnar humeral opening on stress X-rays suggests a medial collateral ligament injury. There's also the milking maneuver, which you can do where you pull the thumb with the arm supinated and the elbow flexed over 90 degrees, or the moving valgus stress test, which is high sensitivity and reasonable specificity, which is you externally rotate the shoulder and keep the elbow flexed and extend it with constant valgus torque, and it reproduces the elbow pain around 70 to 100 degrees, 120 degrees. So like I've said before, the medial ulnar collateral ligament is lax in flexion, the anterior band, and the posterior band is lax in extension. And there's a central isometric band, which some say doesn't exist, which is close to the anatomical axis of rotation of the elbow. And that's where you want to reconstruct at the anatomical axis of rotation medially. It's thought to provide some stability, and it's clinically relevant because that's where you should put your tunnel for fixation. Like I said before, the natural history of this may not be as benign as previously thought, and symptomatic osteoarthritis has been described in some studies in around 50% of cases, and up to 1/3 can get some valgus instability. So non-operative measures are really rest, anti-inflammatories, and early acute rehabilitation, especially for baseball pitchers where we don't see a lot of these here, stretching and strengthening, and transferring the weight from the upper limbs to the lower limbs and strengthening your lower limbs and your core. So they describe that around 50% will return to full sport within 6 months with non-operative management, but there are no predictors of who will return and who won't, and they generally advise a 3 to 6 months rehabilitation program. So an anterior bundle MCL reconstruction is indicated when non-operative management has failed to control the pain and the patient can't return to the sporting activities. So the investigations you can try, like we said before, stress X-rays, an MRI arthrogram, which can be diagnostic, or a CT arthrogram, which I've never seen done, but apparently shows a classic T sign, which is consistent for the undersurface tear of the anterior bundle of the MCL. So there's a single-stranded versus double-stranded reconstruction, and you've got several graft choices, autograft or allograft, palmaris longus gracilis, or tendo Achilles or toe extensors, or they also describe what's called a graft jacket, which is made by Wright Medical, which is an acellular dermal allograft, which I've never heard of. So the single-stranded reconstruction, you can use an interference screw, an endo button, or a Dane TJ hybrid technique. Interference screws have been shown to recreate stability similar to the normal elbow, and the endo button has also been shown to be equivocal to a double-stranded technique. The Dane TJ hybrid technique is an interference screw in the ulna with a docking procedure at the medial epicondyle, and reported an 85% return to sport. Double-stranded reconstructions, there are several modalities you can use: a figure of 8 reconstruction, the modified figure of 8, or a docking method. I'll describe the docking method for time, which is a single drill hole at the axis of rotation of the medial epicondyle, and it's been shown to have a very high return to sport at 92%. With that, you create 2 separate exit tunnels superiorly and anteriorly, tie over a 1 centimeter osseous bridge, and you create 2 drill holes within the ulna. So this is an example here of the docking method, and then there's an example of the endo button method. The surgical technique I'll skip through because of time, but post-operative care, it's important to, with the medial collateral ligament reconstruction, to have the elbow flexed 90 degrees with the forearm in supination. Commence active range of motion at 1 week. That has been shown to reduce your stress in the medial collateral ligament, and active assisted range of motion for 5 weeks thereafter. You should aim for full active range of motion at 6 weeks, and then start strengthening at 3 months. So in terms of the evidence, the strength of intact ligaments is 3 times greater than the strength of a docking reconstruction. strength of a docking reconstruction is equivalent to the strength of the endo button, and the endo button has a greater strength than the interference screw reconstruction. So they're saying really that the docking reconstruction is the gold standard from the evidence that's available currently. They looked at the systematic review of all the techniques. They found that nearly all will, over 80% will return to sport, and the time to return to sport was between 9 and 26 months. However, they do mention a 10% complication rate, and with the ulnar nerve injury being the most common at 6%. Now with these techniques, we don't routinely transpose the ulnar nerve, so the incidence of ulnar nerve injury is less common. And the docking method has been shown in the studies that are available to have the highest return to sport and the fewest complications.